The bones that participate in the pelvic girdle are the sacrum, the coxal, and the femur. The pelvic girdle is composed of 3 joints: the sacroiliac joint, the coxofemoral joint, and the pubic symphysis. We will review these structures from anterior, posterior, lateral, medial, and transverse viewpoints. We will progress gradually, reviewing the most relevant structures of the osseous anatomy, cartilage, synovial capsule, fibrous capsule, and ending with the ligaments. Both the pelvis and the sacrum compose the pelvic ring. The pelvis is the result of the fusion of the iliac, the pubic, and the ischiatic bones. It is a complex bone. The specific structures will be reviewed in another video. The sacroiliac joint is that between the sacrum and the iliac portion of the pelvis. It is the synovial type of joint. In this axial view, we can see that the articular surfaces covered with cartilage are the auricular surface of the sacrum and the articular surface of the iliac bone. Both surfaces are flat but irregular. There are 2 types of ligaments: proper and accessory. These ligaments are the sole responsible for the stability of this joint. As the articular surface is plane, it does not contribute to its stability. There are 3 proper ligaments: the anterior sacroiliac ligament that binds the sacrum and the iliac bone from the front, the interosseous ligament that spans the iliac and sacral tuberosities, and the posterior sacroiliac ligament. The 2 accessory ligaments are distant to the articular area but are implied in its stabilization. The sacrospinous ligament goes from the ischiatic spine to the lateral border of the sacrum. The sacrotuberous ligament goes from the lateral border of the sacrum to the ischium. From a medial perspective, we can see the anterior sacroiliac ligament, the sacrospinous ligament, and the sacrotuberous ligament. All these ligaments are extraordinarily consistent and resistant. It must not be forgotten that although the sacroiliac joint is very stable thanks to its ligaments, it is a synovial type of joint. As all of them, the osseous surfaces are covered with cartilage, and the fibrous capsule is lined with the synovial membrane. The second joint that we're going to review is the pubic symphysis. It is a symphysis type of joint, which means that the content of the joint is cartilage and fibrous tissue. Both pubic bones have a flat and irregular surface. This surface is covered with hyaline cartilage. Both cartilaginous surfaces are united with fibrous tissue, which runs from one side to the other. This joint is stabilized by a fibrous capsule. Also, the superior ligament and the inferior ligament go from one side to the other. The inferior ligament has the form of an arch. Therefore, it is also called the arcuate ligament. The intrapubic disc is a condensation of fibrous tissue within the joint. The third joint of the pelvic ring is the hip, also called coxofemoral joint because of the participation of the femur and the coxal, that is, the pelvis. The lateral surface of the pelvis has the deep acetabulum for the articulation of the head of the femur. The ring of the acetabulum is called the margo acetabularis, which means the rim of the acetabulum. The supraacetabular sulcus is a long, shallow groove around the margo acetabularis. Inside the acetabulum, along the peripheral area, is the lunate surface that's covered with cartilage. The space between the ends of the lunate surface is the acetabular notch. The remaining center inside the lunate surface is the acetabular fossa. At the proximal end of the femur is the head of the femur, which has a spherical shape. At the center of the head, there is a small fovea capitis for the insertion of the ligamentum teres. The neck follows the head. The metaphyseal region has two relevant structures: the greater trochanter and the lesser trochanter. The greater trochanter is lateral. There, the tendons of the gluteus medius and minimus insert. The lesser trochanter is medial and posterior for the insertion of the tendon of the iliopsoas muscle. The head of the femur is covered with cartilage. The fovea capitis is the only part that isn't. The cartilaginous surface of the pelvis is the lunate surface. Inside the joint, there are three fibrous structures. The labrum is a fibrocartilaginous structure along the rim of the acetabulum, which increases the contact surface. The transverse acetabular ligament spans the edges of the acetabular notch. The ligamentum teres goes from the acetabular fossa to the fovea capitis. In a coronal view, we see that the labrum increases the depth of the acetabulum. The synovial capsule inserts at the outer edge of the labrum and along the inner edge of the lunate surface. Thus, the acetabular fossa is intra-articular but extra-synovial. At the femur, the synovial capsule inserts also at the edge of the head of the femur, but then goes distal, lining the neck of the femur. So again, the neck of the femur is extra-synovial but intra-articular. The vessels going into the head of the femur along the neck run inside the synovial lining. The ligamentum teres is covered by the synovial membrane. The hip is a very stable joint because of its ball and socket configuration and also thanks to the ligaments. There are three ligaments, which have the origin in each of the regions of the pelvis: the iliofemoral ligament, the pubofemoral ligament, and the ischiofemoral ligament. The iliofemoral ligament goes from the superior area of the acetabulum to the anterior region of the intratrochanteric line. It has an internal and external fascicle, superficial to the pubofemoral ligament. The pubofemoral ligament goes from the iliopectineal crest and pecten pubis to the more distal part of the intratrochanteric line. The ischiofemoral ligament goes from the posterior area of the acetabulum to the intertrochanteric crest. Watching from lateral, we see that all these ligaments have a spiral orientation going from posterior to anterior. Looking to right hip, we see that they have a clockwise orientation. This means that they get tight in extension and loose in flexion. We can experience this because we are unable to extend the hip much beyond that required for a stand-in position.